It's already magic enough, again, that we can send little tiny pieces of sound, bounce them off of red blood cells through a skull and then back through the skull again, and then make heads or tails of it. That's already magic.
Welcome to the Strokecast. A Generation X stroke survivor explores rehab, recovery, the frontiers of neuroscience, and how to peel a banana with one hand.
Hello, I'm Bill Monroe, and welcome to episode 167 of the Strokecast, using robots and ultrasound to treat and prevent stroke. This episode is sponsored by the fine folks at Modus Nova. To find out if Modus Nova can help you recover the use of a stroke-affected limb, visit strokecast.com/Modus Nova. Transcranial Doppler Ultrasound is a technology that helps doctors see what is happening with the blood flow in the brain. I first talked about this technology with Dr. Aaron Stayman way back in episode 50 at strokecast.com/ultrasound. Transcranial Doppler Ultrasound, or TCD, has a number of advantages over traditional imaging techniques that I'll talk about with my guests today. Dr. Robert Hamilton's company, NovaSignal, developed a robotic machine that has the potential to transform how we use TCD in stroke care and make the technology more accessible to more facilities. Dr. Mark Rubin, a longtime advocate for and practitioner of transcranial Doppler ultrasound, recently completed a study of the NovaSignal device and presented the results at the International Stroke Conference in 2022. The results, frankly, were astounding. Drs. Rubin and Hamilton join us to talk about the technique and why the NovaSignal solution matters for stroke survivors. So now, let's meet Dr. Mark Rubin and Dr. Robert Hamilton. Drs. Rubin and Hamilton, thank you so much for joining us on the show this week.
It's a pleasure.
Thank you.
So, Mark, let's start off with a review here. What is transcranial Doppler ultrasound?
Oh, that's a very good question. So transcranial Doppler ultrasound, while a mouthful, so shorthand for that is TCD. It's a type of medical ultrasound.
I think that was an Elvis song, wasn't it?
But TCD is a type of medical ultrasound that we use to listen to blood vessels and specifically stuff that's flowing within those blood vessels in the brain. So a machine sends out tiny sound waves that bounce off of blood cells or things that are not naturally supposed to be in blood vessels. And we can know how fast and in what direction that thing, whether it's supposed to be there or not, is moving. And that information, coupled with knowing about brain blood vessels and what's normal and what can go wrong, it helps us understand what's happening inside a patient's head.
So how does the data you get from that, or the images you get from that, compare to what you might see on an MRI or a CT scan?
Right. So this is basically the question of imaging versus non-imaging ultrasound. And it's still... there are similarities and differences. The similarities are that ultrasound is ultrasound. You're bouncing sound waves off of tissue of some kind and gleaning some information from them. With imaging ultrasound, which when we're taking pictures of babies or livers or carotid arteries, we're bouncing the sound waves off of tissue and we're gleaning information on how dense or how thick tissue is based on the intensity of that reflection. So that's one way of gleaning information from ultrasound. The Doppler refers to the fact that things are moving. And so this is, instead of taking pictures of tissue, we are bouncing the sound waves off of the tissue to try to know how fast is it moving and in what direction is it moving.
So we're actually analyzing sort of the dynamics of a situation rather than the map of the situation.
For the most part, yes. We can have a sense of, where is a blood vessel in relation to other structures, because we know the only thing that could be moving in a particular direction at a particular speed has to be a particular artery. but it's not taking like a crystal clear picture of it like a CT or MRI would. And that's not necessarily a shortfall of ultrasound. Ultrasound is in every way complementary to these CAT scans and MRI scans, because the CAT scans and MRIs, they take pictures of what's happening at that moment, and it's a static picture. They're far less dynamic than ultrasound can be. And so they're complementary. If the MRI can take a picture of the roads, ultrasound is listening to the traffic.
Which can give us a lot more information in different ways about what's actually happening in somebody's head.
Correct. And I liken it to, when you have a plumber over and they're working on the pipes and they're doing something, they shut off the water and they're just working with the pipes. And you wouldn't send a plumber home without turning the water back on, because you want to know that when things are flowing in these pipes, that everything's going okay. That's when I explain to people why, like, oh, doctor, one more 3-letter test. Like, well, one, this is non-invasive. This is, yes, some of your time, but otherwise I'm just holding a little piece of plastic on the side of your head. But this is to your benefit for these reasons. And that's, since everything comes down to speaking in metaphor, that's the one I usually bring up, because we can all relate to having the need to call a plumber every once in a while.
Absolutely. And a plumber is very apt, because plumbers come in to treat one of two things, either a clog or a leak, or in stroke talk, an ischemic stroke or a hemorrhagic stroke.
Correct.
This is a technology I think a lot of people haven't heard of. Most of us don't know anything about ultrasound aside from what we encounter with pregnancy, or like, when I was in the ER and they were just using the ultrasound to look at my heart for a PFO and do a bubble test, which was interesting because the tech actually injected the air into my IV to watch the flow of bubbles. And I remarked that every time I've seen that on TV, it's because that's how the killer has snuck into the hospital and is trying to kill people. And she said, yeah, they always do that wrong. If you're going to do that, you have to use the entire syringe. So I learned that useful tip that day.
Always the sort of thing you want to hear in a house of healing.
Yeah, exactly. Working on drumming up some business there. But it's not a well-known technology. I mean, why don't more facilities use TCD?
It's hard to do. It's hard to do technically, like just knowing all the information you need to know, and using your hands and arms in the right way to get usable signals, and then looking at the type of information that you get, which is all inferential. It's hard. And then that's putting aside the fact that the skull is a very difficult bone through which one needs to put ultrasound and then get it back. That's a small miracle there, just that we can get any information whatsoever through our wonderfully thick skulls that we need to protect our brains. In a phrase, it's not push button like some of our other diagnostics are, and so it's not nearly so common. It's been around for 40 years. There's a way to do things, and there's an education circuit, and we've been trying, and through my career, I participate in that in a number of these courses to try and train, and it is not kept up with sort of the growth in medical need. They're even 40 years in. There aren't a lot of people, certainly in the United States, but globally, it's an underutilized diagnostic for what it can provide, and to the point that those few of us who do this are like, are we crazy? Like, why are we so into this? Why do we think this is good? But my summation is that because it's a lot harder to do, and we can get by with CTs and MRs. That's been sort of the standard for a long time, that we do good enough with CTs and MRs, and those are essentially push button for practitioners. So that's why it hasn't really caught on, and it's not in every hospital.
Gotcha. And it has a lot of nice advantages. I mean, obviously, being cheaper, being more portable, and not exposing patients to more radiation that they would get if they just go and get another CT scan, but like I say, holding that wand at the temple or the eyeballs or the back of the skull to get those readings is going to require a lot of skill. Now, Robert, one of the things we've got with NovaSignal, you've got a solution to address that with your device. Could you tell us a little bit about that?
Yeah, I suffered through some of the challenges that Dr. Rubin had when I was at UCLA during my PhD training, and that I was selected to learn and how to perform transcranial Doppler in the neurocritical care unit, and realized how difficult yet useful the technology was. And that's really what got me started thinking about how to increase access to this incredible technology. And with that, started thinking about ways to automate certain portions of it using robotics and artificial intelligence.
The technology in robotics and AI has, of course, been growing huge amounts over these last 5 to 10 years. I mean, a lot of my work with adjacent to AI and machine learning has all been in the language space and working with translation products and transcription products and figuring out how to understand voice and turn it into language. Now, when we're talking about TCD, we're talking about, in some respects, something similar, being able to understand sound and translate that into information that physicians can use to make decisions. But when we're talking about robotics, how does this then robotic solution differ from the manual approach?
So the use of robotics for all of these difficulties that we just described is actually quite ideal, because the way I was taught and the way I've sort of honed over doing many thousands of these studies in my practice is very computer-like. There are a number of if-then statements that I follow, and even trying to follow a system, I'm a person. I can be inconsistent. My hand and my arm can get tired. And all of these things are literally impossible with a machine. A machine either performs its task or it doesn't. The physical elements of getting an optimized signal, it actually lends itself very well to not only the robotics, because again, a robotic arm doesn't get arthritis per se, and that's even putting aside the ability of the software to be entirely systematic about is this actually a best signal or not. That's what we do as sonographers to begin with, and I have nothing against continuing to train people to do this. It's useful to patients, and it's personally and professionally gratifying to train and get very good at something. But when it comes to scalability and sustainability, particularly with anything physically rote, the robot is going to win, and that's why we make them in the first place. And it lends itself particularly well to roadblocks to having TCD be more widespread or push button.
And of course, that especially as we're recording this now, we're in the midst of the latest ending of the COVID pandemic, which we of course know is just seems like it's going to go on and on and on as masks are coming back again. But we also have seen hospitals and medical staffs overwhelmed with just so much work. And anytime we can offload some of the more rote and robotic stuff from the professional medical people to robots that can do it really well, that's a good thing.
This begs an anecdote. When we brought NovaSignal representatives to our hospital to consider these devices at the Comprehensive Stroke Center where I round, I had just been with one of my vascular neurology fellows, and we were doing bubble studies the good old-fashioned way, which again, and this is literally my career, it's something I do every day. We had been able to do 3 bubble studies in about 3.5 hours. Which, if you're at about an hour, especially in an educational setting, about an hour per patient, that's actually relatively quick. We brought one of the patients into the Nova Guide, the robotic assisted transcranial Doppler, and the work was done in about 1.5 minutes. to the point that I had to do one of those laugh to not cry kinds of things, because it's like I could have been doing plenty of other things in these other 3 hours if I could have gotten through 3 patients in 15 minutes, because the work is finding the signal, then optimizing it, and then it's usually held by a head frame that's continuous across the scalp. So when you perfect one, you're messing with the other, because all of your physical manipulations are translating through the plastic to the other side. And so then you do this dance back and forth to try to get a perfect signal. And then the actual bubble study part, like when you were getting that echocardiogram, the injection only takes a minute to inject and then listen to see if anything comes across. But all the work comes in the finding and optimizing the signal. So when there's something that can do it that much better than I can, which kind of, if my ego mattered, that if that was of primary concern, like, yes, it does hurt the ego, but obviously the main concern is how do we take best care of patients, and how do we free up the clinical team to be there for patients. And if the robot can beat me as a sonographer, then I have to tip my hat to that robot and let it do what's right for the person. And so I can work on other things.
No need to go all John Henry on that thing.
No need.
So, and then of course, when you're freeing up facilities and people, you're saving costs for the medical team. So we got a better patient experience. We've got ability to practice more medicine for our physicians, and we've got cost savings, which is something that the insurance companies and the administrators can get on board with. So I think what's really interesting is, of course, the key question becomes about some of the accuracy then. Now, a recent study you were a part of actually was looking at comparing a couple of technologies using TCD to look at PFOs versus the TEE test, transesophageal echocardiogram, I believe is what that stands for. I did have a TEE a couple months after my stroke, and what I remember most of that exam was the propofol they used to sedate me, and let me tell you, that was some good stuff. But apparently then they stuck a thing down my throat to look at my heart to figure out, should we do anything about your PFO?
A big mechanical snake.
What can you tell me about the study?
Yeah, so this was fun. We ran a study called Robotic TCD Ultrasound Bubble Study compared to transthoracic echocardiography for detection of right to left shunt. A bit of a mouthful, so we abbreviated that to Bubble, BUBL.
Nice.
And so, and to be ultra clear about that, the transesophageal or TEE was an optional diagnostic in this study, but we tested primarily against transthoracic because that's the frontline standard of care, particularly in American Heart Association, American Stroke Association guidelines of how we look for PFO or any kind of shunt.
And transthoracic means across the chest.
Correct. That's on top of the chest where they look between rib bones.
And how did that turn out?
That turned out well. We, again, used the NovaGuide robotic-assisted transcranial Doppler study. That test was run on patients who are otherwise admitted to the hospital for something that was concerning for an embolic stroke. We ended up with approximately 129 patients that we were able to review all of their data. And the top line, and this is what we presented at the International Stroke Conference in New Orleans in 22, and also in Lyon, France, at the European Stroke Organization national meeting. Out of those 129 patients, we found right to left shunting from PFO or otherwise in 27 of those 129 with the transthoracic, and 82 with the robotic-assisted transcranial Doppler study. So a massive, massive difference between the two.
So we're finding a lot more of these PFOs with the TCD. The question related to that then, though, becomes, are we finding ones that are worth dealing with, or are we finding PFOs that are just too small to really be a stroke threat and then potentially result in an unnecessary PFO closure procedure, or are we finding ones that are a potential issue that we really do need to deal with?
Well, I'll add that all shunts matter, at least initially. We want to know if someone has a shunt or not. And I'm also purposefully referring to right to left shunts rather than PFOs specifically, because we did not view specifically for PFOs. We didn't get either TEE or any other type of sort of definitive where is the shunt. And that was also by design, because in clinical practice, as a stroke neurologist, I don't necessarily care if someone has a PFO or not, or the size of it or not. In the branching logic, the first point is to know, does this person have a shunt such that the vein part of the body has access to the artery part of the body? Because a lot of stroke workup is looking for, okay, from the left half of the heart to the brain, where in the arterial system is there a problem that this person ended up with this stroke issue in the brain, either blockage or bleeding. If there's a shunt, if I can inject some kind of contrast material, that we use agitated saline contrast, so little air bubbles. If I can inject bubbles into a vein and they can be heard in arteries in the brain, which is not supposed to happen, then anything in the veins could cross over and get to those arteries in the brain. So the first point of the branching logic is, does this stroke patient have a right to left shunt, if it's from the heart or otherwise? That's further down in the branching logic. But do I need to care about this person's veins? If they're, a 97-year-old who smoked most of their lives and they have a type of stroke that looks like small vessel disease, and they can have as much PFO if they want. We're not going to close that. And we might still look to see, because they have a shunt, do they have a clot in the veins that could have crossed over? And so we may do a little bit of extra testing to make sure that they don't have any vein clots. But we're certainly not going to send someone, and we have clinical scores that kind of help guide, should we care about this PFO or not. But TCD comes in, and knowing right to left shunts just in general, PFO being the most common of them, but there are other types. The first step is there a shunt? And this study was designed as a shunt detector, because that's what we really care about to try to take good care of patients. Because PFO it's common in healthy, normal people who live with it and die with it, and it's never an issue. And it's common in patients who are young and who experience a stroke, especially if we don't have another identified cause of that stroke. But it's not everything. And we can end up being sort of too PFO focused. So this is taking the step back of just, is there any shunt? And then if there is a shunt, is there a PFO? And if there is a PFO, does it make sense clinically, using these clinical scores and the preponderance of my training and experience, to have a sense that, this PFO is something to worry about? And then is there evidence to suggest, if I close this, that I'm doing right by the person? So we're not to a point where it's, PFO, just automatic referral to cardiology, get that thing closed, and we can all move on with our lives. We're not there. Small shunts matter, but large shunts really matter. They are the greatest worry for, is this something that needs to be closed? NovaGuide found 35 large shunts out of those 82. Transthoracic found 13.
Wow.
The transthoracic missed over half of the large shunts found by the NovaGuide device, so that it missed 18 of those 35. Less charitably stated, it missed or underdiagnosed 2/3 of the large shunts found by the NovaGuide.
And that's huge.
It's totally unacceptable.
Yeah.
This is, I've been metaphorically graying since I've been aware of this technology. Why is transthoracic echocardiography our standard, because it's just, well, if it's negative, okay, whatever. Let's move on. Let's look for other stuff. Yeah, aspirin, high intensity statin, cardio monitoring on your way out the hospital, and good luck. I started to get into this late in my residency training and in my fellowship training, and there was already a 15 plus year body of evidence sort of telling us this, even when I started to become aware of transcranial Doppler's ability to detect shunts as compared to transthoracic echocardiography. In particular, when I'm giving talks, I put up Zoolander's Mugatu of like, I feel like I'm taking crazy pills. Like Zoolander's looks, they're all the same. La Tigra, like he's giving the same look every time. Like, am I crazy for thinking these look the same? And I feel like I'm crazy. Like, what do you mean? You're not shunt negative with something that has a 45% sensitivity, which there are a number of meta-analyses based on observational studies. But in meta-analyses of observational studies, transthoracic is found to be about 45% sensitive, meaning it's if the PFO is there, it's less than a coin toss that you actually detect it.
Jeez.
As compared to transesophageal, being if transesophageal is the gold standard. And transcranial Doppler has about a 30-year track record of being in the 95 to 100% concordant with transesophageal, depending on the series. So we've known this, but this is back to the original part of the discussion. Like, it's just hard. It's just hard to do. And so I was very excited to have the honor and the pleasure of being the national principal investigator for this study, because I've been pulling my hair out over this since I was a fellow. Like, to have the opportunity to give transthoracic, and this is, I have friends who are cardiologists. I have friends who are echocardiographers. It's nothing personal, but the opportunity to give a scientific kick in the pants to transthoracic echocardiography as the standard of care for shunt detection in stroke patients has been driving me crazy as long as I've been a stroke doctor. And so it was with great pleasure that we were able to demonstrate with high quality data what has been out there for 30 years, but in part using cool technology and being backed by robotics and artificial intelligence, machine learning, to be able to scream it from the mountaintops of like, guys, there's a better way to do this.
Right. And the new technology aligns then with the broader cultural conversation around advances in AI and robotics that are happening in other industries. So it makes it a little bit easier now to be able to emphasize that and tell that story, since we've already gotten used to now robots building our cars and doing precision welds. Let's use them also to go ahead and detect those things getting into our arteries that should not be getting into our arteries.
Right. And I invited Robert recently to give a 21st century TCD talk at the American Society of Neuroimaging annual conference. And he has this wonderful slide showing how basically the 40-year model of having the Dr. Rubins of the world who, when they're on, they can do these studies, and when they're not on clinical service, they can go around teaching people. That gets us to about this many studies per year as compared to how many people could benefit from this. And then leveraging technology. It's the scalability that is not only promising, but exciting from a practice standpoint. That, we're just trying to do right by people and try to keep them from having strokes. So we're talking about cost savings, just morally and pecuniarily, the cost savings of doing a good job and keeping people from having strokes is of course imperative here. So, and I should add that it was this specific type of robot, and if other robots come about into the marketplace that can do what the NovaGuide does, great. And let's not great for Robert, sorry, but it is it's worth mentioning because there are other sort of quote unquote robotic devices that we did not use in this study. So just from an evidence-based medicine standpoint, I can't say, oh, these other types of robots, you'll get the same results, because we didn't use those. And also, they're just very different machines. So the NovaGuide is a specific type of machine that does specific things, that emulates what a sonographer would do. So I do think that's worth pointing out. It's because the robot can move autonomously and do a number of things that like a human hand and arm can do. That's why it was able to essentially mirror what's been published for 30 years, with human hands. And so only technology that sort of approximates what we've been doing would be expected to do as well as people have been doing with for shunt detection.
Should this type of exam just be part of the annual physical we go through?
There's no evidence to suggest it should be part of an annual physical. Should we be screening the entire population? This is the sort of thing that would be very reasonable to be up for discussion, because I do think a general health status for the things that we do know, we screen PSA, we screen for colon polyps, and we screen blood pressure. I think up there in that discussion of things that are potentially problematic is whether or not you have a right to left shunt, because we form vein clots a lot more than any of us like to think. A PFO or any type of right to left shunt isn't necessarily a disease until you have a problem in your veins. Then it's a problematic conduit, and especially since it's so low cost and because it's non-invasive. Person's lying down or sitting up or recumbent, you can do it at any phase of care, any little office, any busy emergency department. With NovaGuide, it's lying down in a foam headrest, and someone pushes the probes up, and then you press a button, and boom, there we go.
It's less invasive than my dental x-rays.
Yeah, you don't have to bite down on anything. There are some similarities in the head frames, but yeah, you don't have to align your bite on anything, and the aligning's done for you. The person, there's a cute little medical laser that goes down the forehead and the middle of the nose to make sure that you're lined up. And they place some stickers and a little bit of gel on the side of the head, and then it's bing, bang, boom, make Dr. Rubin look bad. Whether it's the NovaGuide or the traditional study, it's literally painless for the patient. The closest thing to invasive is, for a bubble study, you need an IV. As far as invasive procedures go, having an IV placed is not a huge deal. And thankfully, we have published literature, the worldwide experience with transcranial Doppler bubble studies over the last 30 plus years. There are no reported cases of stroke or TIA. It's with the contrast bubble injection. It's 1 milliliter of air sort of morselized into micrometer sized bubbles. So that's you're not going to hurt somebody with that, and there's evidence to back that up.
So we're seeing lots of advantages to doing this, to understanding what's going on, maybe head off some other problems. NovaSignal is making it easier to do that, leveraging the broader shifts in technology in the industry. So, Robert, as we're talking a lot about stroke and left to right shunt and brain health, obviously, because that's what we talk about here. Where do you see some of the broader applications of this technology that NovaSignal is working with?
Yeah, thank you, Bill. That's an excellent question. We're very excited, and I'd like to thank Dr. Rubin and the other bubble study PIs for kind of highlighting the deficiencies in the current standard of care. For us, this is just really the starting point, as we're looking at a number of different areas, not only stroke care, but beyond that, and trying to understand cerebral hemodynamics and how we can help support our healthcare professionals in making more informed decisions at the point of care, or really throughout the care process. So, as I mentioned, we've started with stroke and the detection of right to left shunts and PFO, but other applications that are currently being used for today include neurocritical care monitoring for vasospasm after subarachnoid hemorrhage, expanding into the operating room for high-risk cardiac procedures, for monitoring flow, as well as embolic activity during those procedures due to the high stroke risk there. But ultimately looking to expand into other areas of traumatic brain injury and even into dementia eventually.
Well, dementia, that's an interesting one because we don't often think about that as related to blood flow specifically, although, of course, a lot of times we don't think of stroke itself as rather a blood flow event. We think of it as a brain event. It's all inextricably tied. So could you talk a little bit about then how this technology works when you're talking about dementia?
Yeah, this is a future application, as Dr. Rubin talked a little bit earlier, today focused on stroke and measurements of blood flow, and really just highlighting, again, the complementary nature of our system to standard of care imaging like CT or MRI. But when we really think about the ability to measure blood flow and small changes in blood flow velocity, any condition that could affect that is something that ultimately we could eventually start to address or help support, again, our healthcare professionals in either diagnosing or development treatments for. So when you start to look, and luckily this is backed up by decades of research as well, looking at dementia and those patients that are showing signs of dementia, what we've seen in the past is that the brain's ability to react to changes in blood flow, or react to stimulus, is actually altered through something called vasomotor reactivity. And this is something, again, very early stages of research, but something, an interesting area of the technology that we could explore with our clinical partners in the future. So better understanding of is dementia or Alzheimer's have a vascular component, which we know true.
I just wanted to back up what Robert was saying, that Alzheimer pathology in particular is associated with vascular pathology. There's often quite a mix, not only clinically, but pathologically, like at the tissue level, one affects the other. And there are a number of transcranial Doppler observational series for a number of things, of vasomotor reactivity and emboli, and the nature of the hemodynamics of blood flowing to the brain that either are causal or associated. We don't quite know. There are fascinating observational series of this could be something we should pursue, but I think Novasignal's technology in particular gives us the opportunity, like we've done with our bubble trial, to do this in a systematic, high-quality fashion, so that it goes from that's a fascinating little thing that someone did at one university, and make it generalizable and get a sense like, okay, is this something that's useful to people, or is this just sort of an interesting thing that you had your lightning in a bottle and we weren't able to really reproduce that. That's a particularly exciting potential application.
And I think it's especially relevant to those of us in this community because stroke does put us at a higher risk for vascular dementia down the road. Plus, we've simply got less living brain tissue to work with going forward, so we need to protect what we have. When a medical facility brings on the Novasignal solution, what do they get? I mean, R2D2 is not rolling into the facility. That would be kind of cool. But what does this whole thing look like? Are they dedicating a room to it, or how does that work?
From the Novasignal side, we have a cart-based ultrasound today that can really be taken anywhere in the hospital. So whether it's neurocritical care, the outpatient environment, if you have a small clinic, or the OR. And what comes with that is our fully automated robotic system, as well as the cloud component, which allows for instant access to that information, to provide that information to the entire clinical team. So this is something that's often wheeled from bed to bed. It is done at the bedside usually, and for those critical care patients, or can be done in an outpatient setting as well.
So not too much bigger than say the computer the physicians may already be wheeling from room to room to do their charting.
Correct.
It's much smaller than like the echo machine that you probably got ultrasounded with back in the day.
Right. And that then also makes it a great option then for smaller or more rural facilities, or potentially facilities in other parts of the world with more challenging medical infrastructure.
Exactly. I think the requirements for this system are simply a plug on the wall. So the ability to move it from place to place and go really anywhere within the hospital or outside the hospital environment allows greater access to the technology, and not only the world-class comprehensive stroke centers like Dr. Rubin works at, but also rural clinics as well.
While we're sort of praising the technology and the scalability, it's not just the R2D2, but R2D2's guts and our ability to provide support for remote facilities. Someone can be doing a study anywhere, and the information can be sent to a local physician, or it can be sent it can be sent anywhere. So whether it's for a second opinion or to extend the reach of, particularly, vascular neurologists aren't sort of enough to cover the whole map. We as practitioners appreciate that Robert's company is trying to do what's been done with some other elements in practice with CT and with MRI, and to be able to bring these studies to us and make it easy to pull them up on our phones wherever we happen to be, whether we're on busy clinical service or, back like we discussed earlier, doing telemedicine from the Maldives. We need to be able to see these things as they're happening. And it's not just the physical machinery to acquire the data, but the software that supports these the data being brought. Because frankly, in the broader picture, because I use all TCD devices that are available, Novasignal is so far the only company of which I'm aware that makes the information easy to get pretty much anywhere, particularly on mobile devices.
And ultimately, it's always the data that matters. It sounds like it's been a good fit for the broader shift toward telemedicine, and especially as we've been hearing more and more in the media in general about the increase in telemedicine around stroke diagnostics and evaluations, and helping neurointerventionists provide better care either to a remote facility or even to start providing information as they are on their way into the facility.
Correct. And this has been an access problem long before Novasignal existed. And it was just the state of affairs that if you wanted to get a high quality transcranial Doppler, you had to go to the person in the university where they may or may not have it. The physical technology, the R2D2, as well as the software platform, totally opens that up.
We've been talking about all this, and we've seen sort of the scope of your career and spanning where we've come from just being, getting introduced to TCD in the earlier days and wondering, why isn't this more useful? I mean, why did you, what drove you to go ahead and pursue a career in medicine to begin with?
I realized long ago that without health, you can't enjoy anything else in life. So between that and having a fascination with anatomy and physiology, which is real, but particularly as you get into the minutia, fits our common use of words like magic or miracle. Putting these together, medicine has been a very good fit. And what I've found through my career is that being involved directly in patient care is, where it all happens, and is the basis of not only developing the expertise, but getting that fulfillment of helping someone in a moment where they really need it. But opportunities like being able to run this clinical trial, which we're proposing and hoping leads to a better way of doing things for patients, not only who are in our trial or who happen to be in our centers where we ran the trial, but more broadly, it just scales, those good vibes. It's great taking care of somebody at the bedside, doing that multiple times a day. And, I help, these people I got to see today. But if we're able to, through good clinical science, add orders of magnitude of the numbers of people we can help, those are good vibes with that many more orders of magnitude. And so that's been another fulfilling aspect of being in medicine. It's all about patient care and doing what we can to take care of the patient, and those are the needs to be addressed. But there are a number of ways to go about that in addition to the direct patient care.
Well, that's fantastic. I love what you said about miracles and magic there. It always calls to mind the Arthur C. Clarke quote for me, which is that any sufficiently advanced technology is indistinguishable from magic.
Right. Correct. It's already magic enough that we can send little tiny pieces of sound, bounce them off red blood cells through a skull and then back through the skull again. And then make heads or tails of it. That's already magic.
It really is. It's pretty amazing how that stuff happens. But as you've got this focus on patient care and seeing this happen, and that's awesome. What was it about the vascular neurology aspect of it that really drew you to it? Because you can get that helping of patients and that patient care in so many different fields in medicine.
You can. And vascular neurology, so once getting into neurology in general, I found myself drifting toward vascular neurology, which is unique within the field in a number of ways, but particularly with treatable ischemic stroke, it's a moment where we can have someone having the worst day of their life in a truly horrifying situation and have a reasonable expectation these days to change the course of someone's life, if not completely reverse the horror entirely, right in front of all of our own eyes. And there are many reasons why vascular neurology is compelling and fascinating, but that alone keeps me on my toes and ready to get at it every day.
Well, that's great. And that's one of those things that wasn't really even a possibility 30 years ago, to be able to reverse so much of the damage from an ischemic stroke. The advances have just been huge. So I mean, Robert, your background has been in engineering and biology, and you've got this entrepreneurial effort here now. What was it that drew you to the medical device and technology field?
Yeah, so long journey looking back, and really for me, it's about the intersection of technology and healthcare, and trying to understand, ultimately how we can improve that through advanced technology. And I came about the field a little roundabout way. Originally, I wanted to build bridges. I was very interested in the structural engineering components of things, but as a collegiate baseball player, I was hurt my sophomore year. And my orthopedic surgeon at the time informed me that it had to do with biomechanics, and that really what shoved me in the direction of engineering and biomedical engineering in particular. But I had an incredible opportunity as a undergraduate to actually travel to China and develop technologies for stroke patients in Hong Kong and outside of Hong Kong. And that really was a seminal moment for me in understanding how we can take new technologies and advance fields. And so that was back in undergraduate. I had the opportunity then to be very close to patient care as a graduate student at UCLA and work in the neurocritical care environment every day. And similar to Dr. Rubin, being close to patient care, I believe, is invaluable as an engineer because you really understand the pain points of the healthcare professionals and the patients themselves. So I attribute a lot a lot of that success to just being next to and involved in that care pathway. And so that was really the motivation for the development of technologies and understanding and seeing transcranial Doppler in particular and why it wasn't used every day was really the catalyst for not only Novasignal but really my career aspirations.
Mm-hmm. It's fascinating to see how all of that then comes together in that pairing of engineering and medicine and seeing a potential solution, and then here you are still being able to go ahead and now bridge what we know from the engineering and the robotics with the potential of the TCD technology to be able to bring that bridge of the Novasignal solution to the marketplace.
Yeah, I think it's a huge benefit to combine multiple disciplines as Dr. Rubin and I think about problems very, very differently. And as a data scientist, as an entrepreneur, combined with the physician and the clinician, the clinical studies aspect of it, really has some powerful outcomes. Being able to combine the best of both worlds and trying to find solutions that allow him and his colleagues to do their jobs better and more efficiently, and allow us to provide solutions to them to enable that.
That's always an interesting balance and partnership to see. We saw that a few months ago when I was talking with Dr. Patrick Brower and Michael Gilvare from Cerenovus, all about their research around clots and then the mechanics of building devices for thrombectomy, being able to pair those different disciplines together.
It is. You have coming from different backgrounds, especially with the hot topic of machine learning and artificial intelligence. Everyone on the entrepreneurial side, as well as the biomedical engineering side, wants to support their clinical partners in that. And I know there's a number of different technologies as we continue to grow and aid healthcare professionals and physicians in making these decisions. But it is a different viewpoint, and it does take a number of people to come to the table, and not only from a technology perspective, but also understanding workflows and how it might integrate within their overall care of the patient is critical for any technology development.
And that brings us to our hack of the week. But first, let's talk about sponsor Modus Nova. Modus Nova makes the Modus Hand and Modus Foot. These AI-controlled, air-powered robotic exoskeletons help stroke survivors recover the use of affected limbs. You already know that to get the limb back, you have to exercise it repeatedly. The key to stroke recovery is in the repetitions. We keep coming back to that theme. The Modus devices that you wear while you play video games for an hour or so every day help you do that. They make the exercises fun, so it's more likely that you'll do them. Plus, the Modus devices can assist or resist your movement while you play to ensure you get the personalized workout that you need based on your existing level of mobility. To find out if Modus Nova can help you recover the use of a stroke-affected limb, visit strokecast.com/Modus Nova. Use promo code STROKECAST for 10% off your first month. And now back to our hack of the week.
But it's the gratitude for being alive and being alive in the 21st century, which we are already blessed to have a number of support systems, familial, government and prostheses and mature therapies for improvement. I encourage folks to continue to look at the bright side there with new technologies coming down the road all the time. Everything from brain computer interfaces just to basic orthoses that keep you from getting keep joints from locking up and medications to keep muscles from locking up. So we have a number of safe interventions that are of use to people. So it's the gaining a disability is not the end of things, because we can still lead good lives even once we're differently abled.
Yeah, and I think that's very well said, Dr. Rubin. And I would add purpose to that. And thank you, Bill, for the awareness that you're bringing about stroke and everything that can be done there. Is the more people are aware of not only treatments but technologies and the underlying condition, the better off we will be, and hopefully preventing future strokes and future neurological conditions as well. So thank you for the work you're doing.
Well, you're very welcome. And Dr. Rubin, Dr. Hamilton, thank you so much for joining us this week. This has been fascinating. I love it when I get to learn stuff about this cool stuff, and about the way we're able to take care of people now, and the possibilities of making things even better in the future.
Well, thank you so much for having us and giving us the opportunity to speak with you and your audience. And I'll echo what Robert said. Thank you for your advocacy and helping to make stroke survivors' lives a little better.
Yeah, thank you very much.
TCD really is a fascinating technology, and I especially appreciate Dr. Rubin's anger at this successful and inexpensive detection technology not being used more often. I'd encourage you to go back and listen to my conversation with Dr. Aaron Stayman at strokecast.com/ultrasound from a few years back. I mean, that's where I learned first about this technology, and even learned that blood sometimes flows backwards in the brain to meet the needs of the brain. All sorts of fascinating stuff. When it came to diagnosing my PFO, I went through 3 tests. I first went through a traditional ultrasound in the ER, the echocardiogram, and then I had a TCD bubble study, apparently as an outpatient, and finally the TEE test, where they sedated me and put an ultrasound device down my throat to get a closer look at my heart. And really, I don't remember a whole lot about that experience because, well, I was sedated for it, but I do remember that the sedation medication they used was just delightful in medically controlled conditions. All 3 of these tests, though, confirmed the PFO with varying degrees of detail, and ultimately, we all decided not to close it. The bubble study test that I did took about 45 minutes of the tech painstakingly adjusting the sensors on my skull. And that's the old way to do it now that the NovaSignal device is available to medical facilities. And if that's what it takes to make this tech more widespread, I wish the team at NovaSignal best of luck in getting their devices out there. By the time this episode is live, I'll most likely have finished reading Mimi Hayes' book. I'll be okay, it's just a hole in my head. Mimi told her story on the show back in episode 122. The book goes into even more depth about her shenanigans. The folks over at Like Minded recently featured it in their book club. It's a great book I'd encourage you to go check out, especially since Mimi is now back from the Fringe Festival in Scotland. Not that that has anything to do with this, but just she's super talented. Anyway, you can find links to this book in the show notes and at strokecast.com/Mimi. Finally, I reached a recovery milestone this past week. I typed a word on my keyboard with 2 hands. That means I now have the dexterity in my affected hand that I can type a word or 2. I mean, it is a long way from getting back to my pre-stroke typing form, but it's a start. And it's just like when I took that first half step in the parallel bars in PT. You know, I mean, it may be a small win, but I will take it. Have you had a win recently? Big or small? A goal you might have achieved, or a little bit of function recovered? Or maybe the start of a recovery on a function or a skill? Quite frankly, I want to hear about it and share it with the community. So go ahead and record a voice memo on your phone or some other audio file and send it to bill@strokecast.com, or just do it the super easy way. Call 321-5-STROKE. That phone number in the US again is 321-5-STROKE. Anytime, day or night, and leave a voice message. That is just an auto-answering Google Voice number, so don't worry, you won't wake me up if you call at 3 in the morning. In your message, tell me your name, when your stroke was, and tell me a little bit about your win so we can celebrate your success as a community. Visit strokecast.com/TCD to learn more about Novasignal, Transcranial Doppler Ultrasound, and to find all the links we talked about here today. Share this episode with someone you know by giving them the link, strokecast.com/TCD. Share your recent win. I mean, we all have them at 321-5-STROKE or by email, bill@strokecast.com. And of course, as always, don't get best, get better. Thanks a lot. I'm Bill Monroe, and I'll talk to you soon.
The Strokecast, Bill Monroe, and Bill's guests provide general information and entertainment, not medical advice. Please do not make any changes to your treatment plan or the execution of your treatment plan without first consulting your personal doctor or medical team. The Strokecast is a proud production of the Currently Speaking Podcast Network.